Hi, everyone. Welcome to the House Healthcare Committee. It's Tuesday afternoon, February 6th. And we're going to spend most of the afternoon talking about audio-only telehealth. I think we're starting with Jen. Yes, even though she's not on my list. We're going to start with Jen because we've done a lot of work on this over the years. We're now at a potential decision point because the work we've done, some changes are coming to an end. And so what we want to do is review what we've done, where we are today, hear from BPQHC and DFR, who've both done reports on audio-only telehealth, and then hear from what the insurance companies are doing, including Medicaid in regards to telehealth. We will also have Jessa from VMS, so we can hear our provider perspective. So we'll get all the data and then we'll kind of figure out as a committee what the next steps are and what some decision points are. So before we do that, I want to put a couple people on the spot. We have Vermont Leadership Institute with us today, VLI, which I went through in 2016 and quite frankly is one of the reasons why I'm here today. So if you want to just introduce yourself, that'd be great.
Thank you. So I'm Jessica Pinkins and I work at Blue Cross.
And I'm Sandy Hoffman. I've been here before for Department of Vermont Health
I was
Access.
going to say, I hope everyone it was really great. Yesterday, I attended a session with them and there were quite a few people attending from agencies that we work with and see most often in here. So that was kind of fun. So anyway, welcome. All right, Jen.
All right.
Good afternoon, Jennifer Carby from the Office of Legislative Counsel. So I'm just going to put up, getting you a little oriented here. So we are looking at, we're going back to 2021, and we're looking at Act 6, which was an act relating to extending healthcare regulatory flexibility during and after the COVID-19 pandemic. So that is a point in time. And to coverage of healthcare services delivered by audio-only telephone. I'm going to skip down to page 15, because this is where we start getting into the audio-only pieces. So there were a few different sections in this bill that dealt with delivery of healthcare services by audio-only telephone. And the first one here, Section 4, was putting it into the insurance statutes to require insurance to cover medically necessary, clinically appropriate healthcare services delivered remotely by audio-only telephone to the same extent they'd be covered as if they were provided through in-person consultation. And so this is similar to the kind of coverage we'd already had for telemedicine. And this is now extending that to include audio only, so not the audio visual, but just the audio component. Also, in that act, in Section 5, there was a new section added in Title 18 in the chapter on health information technology, and now we're calling it telehealth, specific to the responsibilities of healthcare providers who are delivering healthcare services by audio-only telephones. And basically, a provider will be allowed to deliver healthcare services to a patient using audio-only telephone if the patient chooses to receive the services in that manner and it is clinically appropriate to do so. And a lot of the provisions in here are really giving a lot of authority or autonomy to the patient to decide if this is how they want to receive services. Provider can't require a patient to receive healthcare services by audio-only telephone if the patient didn't want to get services in that way. A number of provisions around informed consent and really what it looks like to deliver services by audio-only telephone. Then we get into a couple of studies that kind of set us up for what you're going to hear about today. The first, in Section 6, directed DFR, Department of Financial Regulation, in consultation with the Department of Vermont Health Access, DVHA, the Green Mountain Care Board, representatives of healthcare providers, health insurers, and other interested stakeholders to determine the appropriate codes or modifiers or both to be used by providers, insurers, including Medicaid to the extent that was permissible under federal law, in the billing and payment for healthcare services delivered using audio-only telephone in order to be able to get consistent data collection, identify codes for services without in-person equivalents, and minimize the administrative burden on providers. And it was saying that to the extent possible, this coding should be done in a way that allows data on the use of audio-only telephone services to be identified through VCures, the All-Payer Claims Database. It directed all providers and insurers offering major medical plans to start using those codes and modifiers by January 1st of 2022, and then required DFR, the Vermont Program for Quality Healthcare for PQHC, and to the extent VCure data are available, the Green Mountain Care Board, to present information to this committee and the Senate Health and Welfare Committee by this past December, which seemed very far away at the time, regarding the use of audio-only telephone services in Vermont during calendar year 2022. So it's going to be looking back at 2022 to see what the consumer behavior was like during that time, but we have all of those, should have all of the data from that year by now. And it directed the department, this being DFR, to consult with interested stakeholders so that it could include in the presentation information on utilization, quality of care, patient satisfaction with receiving healthcare services by audio-only telephone, the impact on healthcare costs and on access to services, and then how best to incorporate audio-only telephone services into value-based payments. And the other piece that is sort of timely now is the Section 7 information, and that directed DFR in consultation with DEVA, Green Mountain Care Board, representatives of healthcare providers, health insurers, and other interested stakeholders to determine the amount that health insurance plans should reimburse healthcare providers, what they should get paid for delivering healthcare services by audio-only telephone during plan years 22, 23, and 24. We are currently in plan year 24. It directed DFR in determining the reimbursement amounts to try to find a reasonable balance between costs to patients and the healthcare system and reimbursement amounts that wouldn't discourage healthcare providers from delivering services as appropriate by audio-only telephone. It allowed DFR to determine different reimbursement amounts for different types of services and to have different rates for different years as appropriate. But they had to be finalized by April 1st for plan years after 2022. So this is the last year for which there is a specific VFR set reimbursement rates for audio-only telephones. I think that is also part of your role in considering what to do going forward. And that is really it. The rest of it gets into unrelated or related, but.
Any questions on this point topic?
Back in chapter 5. Section 5.
Okay. Page 17.
Page is a step.
17. Middle of 17.
Yeah.
Yeah.
So on that sentence, on the B1 where it talks about a healthcare provider may deliver healthcare services to a patient using the audio only if the patient elects to do so. And then it goes on to say, in a manner that is clinically appropriate to do so.
Right, so if I just want to make sure we have the language, that we're reading the same language. So if the patient elects to receive the services in this manner, and it is clinically appropriate to do so.
Yeah.
Okay.
And where does the Centers for Medicare and Medicaid services come in to that decision-making process?
So it's subject, the beginning of the sentence is subject to the limitations of the license under which the individual is practicing. So subject to what their licensing says.
Yeah.
And for Medicaid patients, to the extent permitted by the Centers for Medicare and Medicaid Services.
Yeah.
So CMS may not allow or may not pay for services to be delivered or certain types of services to be delivered by audio-only telephone.
Okay, so if the patient's provider, the physician, feels it's necessary, the Centers for Medicare and Medicaid trump that physician, is that?
Well, it wouldn't be paid for. I mean, so the idea here is to the extent for Medicaid patients, to the extent permitted by CMS, a healthcare provider can deliver services if the patient says yes and the provider thinks it's appropriate. If CMS says no, then you don't get to the rest of that sentence because it's beyond the extent permitted by CMS.
Okay. Thank you.
Anyone else have a question for Jen? Okay, thank you. So Sebastian and Ally, does it make sense for one to go before the other?
Yeah, we had a plan, Sebastian Lego, for the Department of Financial Regulation.
Do you want to join us or is the plan not to join us?
Yes,
Okay.
but we had a plan for how to present the information.
Okay, great.
So I would go first and then, the part of the presentation, then Ally will present and then I will conclude.
Perfect. Come on up.
Okay,
You need a whiteboard?
yes, I have it ready.
You have it.
Already, well done.
First thing we did when we walked in our.
Was
door,
grab the
we found,
whiteboard?
like,
Katie Porter.
So I want to thank Jen Kirby for that great introduction to the topic. And I brought the whiteboard just to give you the big picture overview of what we're talking about. So telehealth, audio visual, audio only, just audio, Store and Forward is basically email, where you take a picture, send it to somebody, wait for them to respond. Under our statute, telehealth reimburses at the same rate as in-person services. Store and Forward reimburses at a rate that is negotiated between the payer and the provider because there is no in-person equivalent to sending an email. So that leaves audio only as the service modality that the legislature has specified the department to set a rate for under Act 6. So I want to start there and tell you a little bit about what we did and why. So I'm going to advance my slide deck.
And while you're advancing, and you're not showing anything, I don't know if you want to show or you're just going to talk to it.
I'm going to show.
Okay, great. So while you're pulling it up, I just want to remind people where we were when we did this, which was probably on Zoom. Legislating.
We were on Zoom.
And the newbies had no idea what was going on.
Right.
Absolutely not.
And we were in the middle of a pandemic and we felt it was important to allow audio only for access during the pandemic. Great.
So under Act 6, we were required, working in consultation with DVHA and the Green Mountain Care Board, to determine reimbursement for audio-only telephone services for the next 3 plan years. So that was 2022, 2023, and 2024. During 2021, you had mandated that audio-only services reimburse at the same rate as in-person services. So over the course of 2021, we met with a group of stakeholders that eventually turned out to be around 83 different individuals, entities, providers, payers, and the Department of Vermont Health Access. And we received proposals for how to make this work from DVHA, Cigna, MVP, Blue Cross Blue Shield of Vermont, and the Provider Coalition. And what we ended up doing was to, as far as coding goes, to adopt what Medicaid was requiring for how to code audio-only services, because Medicaid had been doing it before the commercial insurers had, and we thought it would be easier for providers to just do that instead of doing something different just for the commercial payers. So in that respect, we required coverage of the CPT codes that are specific to audio only, plus in-person CPT codes with a modifier to denote that those services were being performed audio only. And then we also set a floor for audio only services. What we told payers was basically like some audio only services, like we've heard in this working group, have like really great value, and we want you to recognize that value. Others might be of more questionable value, and we as DFR are not in a position to make those kinds of judgment calls. So we gave payers the option to have a bifurcated reimbursement scheme where if some services were deemed valuable by the payer, they could reimburse those at parity. And if other services were deemed less valuable, they could reimburse those at a lower rate, but no less than 75% of the in-person rate for that service. And again, the reason we did that was because we, as a department, like I've said before in this committee, I'm not a clinician. I don't have the kind of expertise necessary to determine when a service performed audio only is as valuable as an in-person service. But we do know from all of the work we did in the audio only working group that having access to audio only makes a huge difference, and particularly for patients who might not have another way to see their provider. So,
Do you mind a question or two?
yes.
You do
Yes, do you
mind?
mind, or it's okay?
No, I'm happy to.
Mark,
Is there, in what you just said about the 75%, and having the insurers make a determination whether audio only qualified for parity or something less than that, was there a mechanism by which providers could be involved in that decision?
We involved providers in the working group, but left the determination of how to value those services at the payer's discretion. So to that extent, the answer is no.
all right.
With that said, did they set a standard for certain services to be at certain levels, or was it
Yeah,
every individual one was individually decided?
yeah. So what the payers ended up doing was different depending on the payer, but I'll just break it down into the big three, that is Blue Cross Blue Shield of Vermont, MVP Healthcare, and Cigna. So Cigna decided that they were just going to pay everything at parity with in-person services.
Okay.
Then Blue Cross and MVP decided that they were going to reimburse physical health services at 75% of the in-person rate for those services and reimburse mental health services at parity with in person.
Okay. So it's just a flat thing?
Yeah.
Okay, thank you.
Any other questions? Okay, go ahead, Sebastian.
Okay, so part of the work that the legislature asked us to do under Act 6 is to then take what we learned in terms of utilization and report on it to you in conjunction with VPQHC and the Green Mountain Care Board's VCures team. So we, over the summer, worked with VPQ and their subcontractor, Policy Integrity, to produce a report that attempts to outline population level trends in Vermont using audio-only care. And over the fall, we met with the Provider Coalition and the payers to collaborate on the analysis, basically telling them about the methodology we proposed using and asking if there were any concerns with that or if there was a better way to look at audio-only utilization. I think Ali will probably go into this too, but I think it's important to note that the standard limitations with VCures apply here too, in that VCures doesn't capture self-funded plans, federal employee plans, or self-pay patients. And most importantly, in terms of talking about the value of audio-only services, clinical data is not captured in VCures. So we can see that a claim was made and that it was performed audio only, but we otherwise don't have an idea of like the circumstances that surrounded that encounter clinically. Like, was the patient in a snowstorm? Was it an emergency? So just to be clear, we don't have that kind of nuance. And again, Ali will talk about this more, but the analytic approach we eventually determined to use for this report was based on the procedure code modifier. So those modifiers are required in the department's audio only order, and the place of service code. So when you're submitting an audio only claim, you're supposed to put in a code to indicate that the service was performed while the patient was at a remote location. So those were the things that we were looking for. And I think with that background explained, I'll stop here for any questions about our process and stakeholder consultation, and try and answer any of those questions as well as I can before turning it over to Ali to talk about the analysis.
Great. Any questions for Sebastian? Okay, great. Thanks. Ali, you had me confused because you were also on the screen.
My avatar, yeah. I'm hoping to connect by the Zoom to share the presentation.
Yeah, no, that's great. Welcome. Thank you for having me. Yeah, thanks for being here. Good. Playing.
Wait, I didn't open it up.
Please.
That's cool. They're well.
Sometimes it takes a second. Okay.
Great. Yeah, go for it.
Well, good afternoon, Chair Houghton and committee members. My name is Ally Johnson, and I am a quality improvement specialist with the Vermont Program for Quality in Healthcare. Today, I'll share the results of the study that Sebastian was talking about. It looks at telehealth use in Vermont for a couple of years before the pandemic and the 3 years of COVID. So I'll go over the purpose of the report. I'll repeat a little bit about the information used, but this time with pictures. The questions we asked, the findings we gleaned from the data, and lastly, a few thoughts on the intersection between clinical quality and audio-only telehealth. So the Department of Health contracted with BPQHC and Policy Integrity. So that's Steve Capel. He'll be joining later virtually at 2:15, hopefully, to examine population level telehealth trends and claims data. Okay, and so Steve will address any technical questions. He did the lion's share of the analysis and the writing. I would like to acknowledge the Department of Health for financially supporting the project and helping us access the data set through their data use agreement. So as we mentioned, the study used data from BCures, Vermont's all-payer claims database. So we focused on the healthcare utilization data that insurers and providers have to report by law. I want to reiterate Sebastian's point about this not including clinical data, so limited to claims data. Skip the other caveats because he mentioned that, insured and other things are not included in the data set. I also want to thank the Green Mountain Care Board for allowing us to access the data and being so very responsive to requests to review analysis and findings. And please note that these are the findings of BPQHC and do not necessarily reflect those of the Green Mountain Care Board. Okay, so I just wanted to kind of share, this is a little about the methodology, so please forgive me in advance, a little process oriented, but just to get us thinking about what is and isn't included in the report. So here's a picture of a claims form. And we started with services that generated a paid claim. So things that were not billed or paid for, like communicating through patient portals like MyChart, that wasn't included. Next, it's limited to professional services provided by individual providers only. So anything from a hospital or nursing home, that would be excluded here.
Could you say that again?
Yes. So this is about doctor's visits and visits with other healthcare professionals.
Okay.
So any kind of service that was received in a hospital or nursing home setting wouldn't be included.
Gotcha. Thank you.
Another question.
So you didn't include data from providers in a hospital setting who bill on a CMS 1500? Or nursing home?
Can you
The claim
that
form.
in English?
So the claim form
Yeah.
would be any provider, regardless of if that provider is in a hospital setting, a nursing
Right.
home, or an
And we
outpatient.
filtered out all of those claim forms and we only kept certain ones for the analysis.
So just outpatient
Individual providers. So I don't
provider,
know how,
outpatient.
for example, if you go to present to the emergency department with a broken arm, you have a provider bill and a hospital bill. Steve could answer that.
Okay.
I believe it's based on the service being provided by an individual. So that in that case, it would be provided by a hospital, I believe excluded, but we'll confirm.
We'll come back to this when
Okay,
Steve
okay,
shows
okay.
up. That'd be great.
It's mostly think about like office settings, clinics, and yeah. It's limited to the largest payers, so Medicare, Medicaid, and the big three that Sebastian mentioned. We weren't able to include smaller private payers because of the changes in the coding and among the private payers.
Yeah, and I want to just remind everyone, when Sebastian and Jen both talked about the section where DFR worked with others to come up with a set of codes, That was specifically so that we could have a data set. So everyone was using the same code, so we could get to this point and be able to do the data. So.
You're gonna love my next slide.
Thanks.
May not be what you're expecting. So then we have the dual eligibility issue. So if a person's service got paid by more than one company or payer, we included just the primary claim, so we avoided duplication. And then lastly, we limited it to the 5-year span of the study. Okay, so, you know, this idea of having these set codes.
It really works.
We went and needed to look at the full 5-year period because we wanted to compare
Oh,
before and
right.
after. And so Act 6 went into effect, I believe, for claims dates of service 2022. So we wanted to look for qualities of claims that were comparable over time. And we were very lucky, as Sebastian mentioned, to have support from payers who could help us understand those changes in reimbursable codes over time. And with their help, we decided on an approach for identifying audio, visual, and audio only. And I should stop here and just mention, I'm going to use the word telehealth a little differently than the whiteboard. I'm going to use telehealth to mean audio, visual, and audio only.
Okay.
So let's see. There wasn't, anyway, I just wanted to stress there was no universal sign on a telehealth claim for us to be able to identify. Initially, we thought there was going to be a flag. This is a
Right.
telehealth claim, and
That wasn't.
that's not how it worked out. So we had these very specific methodological approach to based on a person's place of service or the procedure modifier. And Sebastian mentioned the two at the bottom, V3, V4. These are, I'm going to kind of go through this because it's in an appendix in the report and Steve will be on later to address technical questions. But these are the three evaluation, evaluation and management. It's written right there. I'm like, evaluation and management visits. And so if a claim for whatever reason had one code saying it was audio visual and one saying it was audio only, we counted it as audio visual because there was some component of visual. Okay. So now we're moving toward the findings, enough on methodology. We wanted to know mainly three things. How has it impacted utilization of professional services? What are the patterns of audio visual and audio only? And has the pattern of telehealth provider location changed, meaning what state they're providing the service from? And you have a copy of this report in your materials. It can be accessed on our webpage, www.bpqhc.org. So looking at all professional services, so in-person and telehealth combined, the dotted linear trend line shows that over time, there was a decrease in all professional services. And the solid blue line is the actual count. You can see it dipped in 2020 during the pandemic and rebounded, but kept with the pattern of decreasing with time. This might be due to changes in the market share of the 5 payers we included in the analysis or the people covered and included in BCures. But it's kind of hard to know. Then I'm going to look at what's underneath that overall line by showing that the in-person visits are in gray. So you can see that's the lion's share of care being provided. And then the audio visual are in orange. And then that relatively tiny amount is the overall amount of audio only service that got provided over this time.
If I could, just a quick clarification. So I'm just looking at 9 million visits. That's over 4 years for 620,000 people.
That's in 1 year.
2018.
Oh, I see from 8. Okay, I didn't look at the bottom.
Yes,
So
please.
9 million visits for 620,000 a year. I'm just a little awed by that. No, so that's a-
Claims.
well, but each claim's a visit.
Oh, no.
Not necessarily.
Sebastian?
So
Makes a lot
an
of sense.
encounter could have multiple claims, depending on what was done.
Oh, Steve's here and could maybe speak to that.
Yeah, okay, because that was a lot, that seems like a lot for our small little tiny state.
I thought it was deduplicated, but please, Steve, go ahead.
Am I live?
You are. Hi, Steve. If you can introduce yourself for the record, that'd be great.
Hi, I'm Steve Capel. I did much of the analytic work on this project. Without going too far into database geekdom, what we're being counted there are lines on a claim. So a
Lines on-
simple claim will have one line. I went for my annual physical. A complicated claim could have 10 or 12 or 13 lines. So telehealth typically was a single line. But other things may be more than one line per claim, per encounter.
Yeah, like.
I went for my physical and I complained about an earache and I complained about a broken toe
And I got my tetanus shot.
and I got my tetanus shot. I don't know.
I went in for my annual physical and they drew blood for my lab work. They took a chest x-ray and that's already 3 lines on that claim.
All over the phone.
Okay. No.
Okay.
All right, let's answer first.
So I think I'm even more confused now, though. So you're saying that like that 9 million in 2018, that's 9 million lines? Or is it 9 million claims?
It's 9 million lines.
On a, okay.
You could
Okay,
have multiple,
Yeah.
multiple services in a visit that is represented on one claim. Do I have that right?
Yes, that's an example of the simple visit with the doctor line, the x-ray line, the blood draw line. For audio visual or audio only, they're almost always single line.
And
hard to
Steve,
do procedures over the phone.
Especially
had
the
a-
blood ones.
an earlier question about care provided in the hospital setting. And whether, you know how, you get a bill from the hospital and there's a provider bill and a hospital bill? In the case that, care happened in the hospital setting, is that totally omitted, even though you might see a provider bill?
It would certainly be omitted from telehealth.
Yeah,
Well,
just
actually,
didn't know.
not necessarily. Because, I mean, if you're in the emergency department and they do a consult, you can have telehealth as a consult. A specialist is dialing in.
Yes, that is totally true that there can be professional to professional telehealth. I tried to get those out of these numbers, but it's hard to really cleanly identify.
We have one more question. Art?
Well, I maybe Alyssa's question kind of answered it, but it seems to me that if you're in person, you could have a number of lines, but if you were on audio only telehealth, you wouldn't have the same number. So maybe we're not comparing apples to
That's
apples.
what I was just gonna ask. So we see like, you know, a lot of the in-person, right? So, but that's a lot of lines versus we see very little audio only in comparison to the in-person, but it's probably only one line for audio only. So when you look at number of visits versus number of claims, we might have more audio only claims than we think. We thinking of that the right way?
I think I would probably turn that around and say, if this was boiled down to visits, then the difference probably wouldn't be quite as dramatic. Just because of what you're thinking about, that in person, I could possibly have 3 or 4 or 5 services during a single visit. But telehealth probably almost always is a single service.
Okay, great. Great, thank you.
And moving on to the
Moving on.
big table. So this table breaks down the previous slide that showed in-person, audiovisual, and audio only further by payer in the rows. And I'll walk through these three key takeaways one by one. And this is my version of the whiteboard. So looking at all provider services combined, the rate of services, and so we calculated the rate of the services by 1,000 members in a paid payer plan. So the rate of services used by Medicare and Medicaid members was higher than the private payers. This is all services combined. And then thinking about audiovisual only, those are most used by Blue Cross Blue Shield and Medicaid beneficiaries.
Well, that's what circled in green. Oh, on our slide looks different than, oh, there it is.
Yeah, I
so you're
do
probably-
animation to try to just
That's
walk you
beautiful.
through.
I was just looking here. Thank you.
Yeah, it's a flat there, yeah. And then rates of audio-only telehealth services were highest among people covered by Medicare, Medicaid, and Cigna.
I have a question. I don't know if it's for Ally or Sebastian. So you said Cigna paid everything at parity through, okay. And then Medicaid and Medicare, do you know how they paid?
I defer to Medicaid for more information about how they paid for audio services.
Okay. Is it a quick answer?
Yes.
Okay.
Alex McCracken, Department of Health Access, we pay.
You pay at parity. Okay, thank you.
Okay, thinking about one of our key questions, what are the patterns of audio, visual, and audio only use? We understood that mental health care was being provided by telehealth. And we wanted to know how much of that was audio visual versus audio only. And so here you see a table showing telehealth service counts. And all those rows are different diagnostic categories. And I've highlighted in green the mental health diagnoses. Terminology comes from a coding manual, not our terminology. And again, this is limited to 2022, and we have that robust coding regulation, and with, things are pretty settling down with the codes. And Act 6 asked us to look at 2022. So two main takeaways. People with mental health diagnoses use nearly 80% of all telehealth services. And then, but on the other hand, the portion of all telehealth that was audio only was the lowest among people with mental health, receiving mental health care. So,
So can you say that again?
so yes, we'll do it with the color.
Yeah.
So if you think about with the numerator being telehealth and the denominator being all services, Medicaid, mental health care has the largest portion. When you think about audio only in the numerator with all telehealth in the denominator, it's the smallest for mental health. So people who are seeking mental health care are getting audiovisual help, and a lot of it. It's kind of contributing to that big orange bar we saw.
Right.
But it's not driving the use of audio only relative to, I mean, it already has this large telehealth share.
Right.
But relatively speaking, other diagnostic categories have a greater portion of telehealth being attributed to audio only.
Okay,
Okay.
got it.
Yeah.
Could you
Daisy?
give an example?
Is this during the calendar year or fiscal year?
Calendar year dates of service, 2022.
So this
And the
is kind of the
PHE
tail-
ended May 11th, 2023.
Yes, around there.
That's what I was just thinking. So instead of the numerical format, I'm thinking how people coming out of the pandemic we are, kind of hungry to connect. So I was thinking we were sick of Zoom by then, but I guess not.
Case in point.
Yeah. Sorry, Alan.
Yeah, it kind of piggybacking on what Daisy just said, I can imagine there's lots of factors in here as to why that is. You know, a low level of audio only versus the whole amount, other than that they don't want to do it that way. I mean, will you analyze those figures further, or are you just presenting them here only?
I haven't. I would invite Steve to respond, please. Oh, he's there. The next slide does look at age by audio only and audio visual and by diagnosis, so we can look at that a little bit.
Yeah.
I think because they were using claims data, I think Steve's coming back on. Steve, if you can pop back on. I think the question is, did you analyze the reasons why people were using audio only or audio visual or not doing any of it?
I didn't have any access at all to their decision process.
Yep, that's what we figured.
Of the data.
Okay, thank you.
Just curious.
Can you talk a little bit about I guess it's the third column over the middle one, the percent of total audio only services, the 62.1% for mental disorders?
Right. So that's, if you take the 27,000 audio only is the count of audio only visits and divide it by 44,554 at the bottom of that column. So thinking about all the diagnostic categories and all of the audio only visits, that's the total on the bottom of the table. And so that's what we're having 62% would be 27,669 divided by, it's the majority of 44,554.
Okay.
And then you do that again with the audio visual, the 599,000 divided by 714,000. That's 84% of all audiovisual visits were in the mental health category. And then the last column does the math different. I struggled with this one too, and I
see it.
Okay, and so that's you see it now. Okay, so that's 27,000 divided by the total of 27 plus 599. Okay, great. So then we wanted to know, since mental health services represented such a large part of telehealth that year, what does that look like broken down by age? And so you see the orange line, so category F is mental health diagnoses. The orange line is audiovisual, and on the x-axis below is age groupings. So the gold line is all other diagnostic categories, audiovisual. The blue line is mental health, audio only. The gray line is all other diagnostic categories, audio only. And the takeaway here is that services for people with mental health diagnoses accounted for over 90% of all telehealth use in ages 10 to 34 and declined as age increased. You can see at 70, the comparison of audio only versus audio visual really changes. Okay, final finding. Oh, go ahead.
This isn't referenced in your slides, and I know we're doing telehealth here, but I'm just trying to get a comparison. Do we have any idea how many claims, I guess, total there were with mental disorders on it? I mean, that's a staggering amount that's 626,000.
That's telehealth.
Just telehealth.
But we know that
Of the whole is.
is it?
I don't think you had to break that. That's okay. I don't.
Sorry, I might be able to look at it in the report later. I can't
Okay.
retrieve it quickly. Sorry. Thanks. So this is the final finding I wanted to highlight, and this is thinking about the state where the provider worked. And I made a little call out to show the detail for the 2 years before the pandemic because the numbers are so small to try to show. And so here we see the Vermont providers in blue, New Hampshire in orange, Massachusetts in purple, New York in yellow, missing information about this variable in gray, and then providers from all of the other states combined in green. And the takeaway here is that telehealth services shifted from mostly being given by other states' providers to being given by Vermont providers. And one explanation might be people continuing to use local providers but switching over to telehealth.
It's interesting.
Those are all the charts. And then just because I'm from Vermont Program for Quality down here, I wanted to bring us back to claims are not clinical records. So a lot of the information we typically use to evaluate quality just was not available to us. And what we realized more research is needed on the quality of care being delivered through telehealth, including audio only. I will mention, though, that we have been tracking the national research related to this intersection between clinical quality and audio only telemedicine. I've taken it on the last couple of times. So once every 6 months, I review the national literature and do a lit review and then update the spreadsheet that's also available on our webpage. And so there are, and it's pro and con. I mean, it depends on the study. It depends on the population being studied, but most of the studies are in support of the availability of telehealth is helpful for people to be able to access health care. So, but there's a lot of detail in this tracking sheet. I've tried to summarize kind of each one so you don't have to read the whole paper.
Yeah, and I like it. It's really fabulous.
Okay, great.
Yeah, if you go on the website, it's really great.
Oh, great. Glad I have some membership here, readership.
Yes.
Just want to clarify your last statement. You said that it's better to have audio only than not any. Is that a good conclusion or?
Yeah, there are studies that support audio only as an important factor in increasing healthcare access for certain populations. A lot of them marginalized populations.
And I think we heard when we took testimony from folks during the pandemic, there was a lot of, can't get to the appointment because I don't have transportation. Or, I have kids at home from school, so I'm going to switch to audio only. And we're going to hear from Jessa, and we can always hear from FQHC, so we can get some more information about that. Art?
Oh, I was just going to ask if there was any negatives to it that stood out, anything where it doesn't work or it hasn't filled a need. I didn't know if there was any of that. And maybe it's in these reports here, I don't know.
Yeah, I'd have to refer to the tracking sheet.
Okay.
I mostly prepared the positive ones for this committee.
Well, and that's fine, and that's fine. I imagine most of it is positive.
Yeah, I could address that. Again, it's Sebastian Window for the Department of Financial Regulation. There have been studies that have found negative impacts to audio only in cases where specific groups of patients are encouraged to choose audio only over other service modalities when those modalities are available.
Huh. When those modalities are available.
Yes. So if you can come in person or if you can do audiovisual telehealth and you're being pushed by your provider to do audio only, that's where there have been problems. But as Jen noted earlier, under Title 18, a provider has to get a patient's informed consent to do audio only. So I would say that it's not as much of a problem in Vermont with those protections.
Okay.
Oh, okay.
Okay. Yep, thank you.
So in closing, I wanted to thank the many individuals who met with my colleagues and me to help understand the data and what we should be studying. And a very special thanks to Steve
Thank you, Steve.
for analyzing the data and drafting much of the report. And it's been a pleasure. Thank you.
Great. Thank you. Sebastian, you're coming back?
Hugh?
Thank you, Ally.
Good night. Back to work.
So what I wanted to close with, since you'll hear from the Provider Coalition about their experiences with audio only and from the payers too, is the department's analysis of the cost impact on commercial insurers for audio only services. And the conclusion that we reached was that because overall utilization trended downward from 2018 to 2022, even if audio-only services were reimbursed at parity across the board, it would not have made a difference because the cost of care still would have increased consistent with increases in medical trend in that period. So our takeaway is that reimbursing all audio services, all only audio only services at parity would not have a cost impact beyond annual increases in medical trend.
Great. Any questions on that? Okay, great. Thank you very much, Sebastian. Thank you, Ally.
Thank you.
Alex?
Joining back to the table.
Yes.
I do have a slide deck. Claire, are you able to share that for me?
We have you pull it up here. Whatever's easier for Claire.
I can pull up on my end as well. I just need to. Thank you, Claire. Good afternoon. Thank you, Madam Chair and members of the committee. For the record, my name is Alex McCracken, Director of Communications and Legislative Affairs for the Department of Vermont Health Access, or DVHA. I'm glad to be with you here today and quite excited to be delivering prepared testimony to this committee for the first time.
Welcome.
To start with some background, so next slide, please, Claire. As a result of the public health emergency, we opened up codes for audio-only and telemedicine in general. Prior to this, telehealth had been allowed but underutilized. We expanded access and allowed telehealth and audio only for many services so that Vermonters could continue to access their medical care providers safely and easily. It should be noted that audio only was always meant as an exception for when in-person or telehealth options are not available. And as a definitions term, I'm also using telehealth as an inclusive term to include audio only as well. DVHA, and I'll correct really quick on this slide, that there's a note that says we are making a spreadsheet with the requested codes. That should be past tense. We have made a spreadsheet with the requested codes. Each time a code was requested as audio only, we recorded it and consulted this list. And eventually a very wide variety of services were allowed to be audio only. We can go to the next slide. Then the public health emergency ended and disallowed many of the services that had been permitted as audio only. In our work on this matter, we have gone through the codes to determine which audio-only services we can continue to cover. In this process, we first verify if there were coding errors and if Medicare allows it, and then affirm a decision from there. Our decisions never go against the correct coding. Concurrently, Sandy Hoffman, Deputy Commissioner for DIVA, convened a stakeholder group to talk about audio-only services that included Vermont Care Partners, Vermont Association of Hospitals and Health Systems, Bi-State Primary Care, Vermont Medical Society, and Vermont Health First. In gathering this group together, we discussed limitations and fiscal concerns. Next slide, please, Claire. Thank you. On July 1st of 2023, we posted all the codes that would be allowed. This was based on all requested services for the last 4 years. Every code that was requested for audio only and telemedicine was reviewed and determined whether it was acceptable. After the flood in this past summer, we were very generous with our allowance for audio only. DIVA's Special Investigations Unit conducted monthly reviews of audio only codes and exercised as much flexibility as possible in response to the flooding. For example, if a code was not allowed for audio only, providers are required to maintain documentation to show why it's necessary and why it was the exception, should the department request that information, but we were not asking for it right up front. Through this process, the stakeholder group, along with the Clinical Utilization Review Board, CURB, and the Medicaid and Exchange Advisory Committee, the MEAC, reviewed and weighed in. The department spoke to each group in November on seemingly excessive audio billing that we were seeing. DIVA asked providers to reach out to their own networks to ensure the issue was being looked at. Ultimately, we determined that it originated with a small number of around 5 providers, and so it turned out to be a billing error that has since been resolved. So we're back on track in that regard. On our website, there is a telehealth page with a list of codes that are audio only. If it's not on that list, there could be several reasons for that. There may be a more appropriate code, or it could be that the service is incorrect to code as telehealth. It's also possible that it may not have come up yet as a question to review. The current list is about half of what the maximum allowable codes were at the height of the pandemic. We did analyze how often they were used. If it was something that was only used once and also not allowable by Medicare, and or not correctly coded, then we wouldn't allow it. Next slide, thank you. Currently, these codes are allowed through the 31st of December of this year, 2024. We are continuing to gather data on utilization, and we have seen a decrease in utilization overall for telehealth and audio only since the height of the PHE. Utilization is decreasing steadily. Some codes remain stable at an increased level, and we don't know exactly what the level off point is for specific services or overall. There are many variables to consider on this, such as overall member caseload for Medicaid and the expansion of broadband access that would theoretically decrease the need for audio only. Again, we should note here that audio only is only ever supposed to be the exception for care, and that prior to the public health emergency, providers could not bill for audio only. Next slide, please. Our main concern is essentially this. If we see an increase in the number of office visits, a decrease in the number of enrolled members, and an increase in the number of audio-only services, then we can reasonably believe that the audio-only services are being billed in addition to the other visits, ending up with DIVA paying for both. We see this as a potentially significant cost driver. So if a member and provider speak over the phone and in office covering the same information each time, Medicaid can be on the hook for both. This also means that if a provider calls a Medicaid member with test results, for example, that exchange could be billed under audio only, which again bills at parity.
Are we seeing this as an issue today, or you're just concerned this could be an issue?
This is an issue today, yes. This is how it's currently set up.
So it's an issue the way it's set up. It's not an issue that providers are trying to bill two things.
Correct. This is allowable.
Okay.
The concern is that this is allowable.
Okay.
Yeah.
Could I clarify?
Yes.
So it's allowable today, Alex? It's allowable to do that today?
If it's correctly coded with the
If it's
list that we
correctly
have.
coded.
Correct.
So you can talk on the phone, get reimbursed, then come in and get reimbursed too.
Correct.
Would that be the same day?
I don't believe that would factor into that now. Thank you. Next slide, please. At the end of the day, we want to ensure members have access, but we also want to ensure that that access is clinically appropriate. In this, we are trusting providers to communicate with members, and we have asked SIU, the Special Investigations Unit, and DIVA's business office to monitor utilization. Should there be a pattern of inappropriate code use for audio only, SIU may investigate with the assumption providers will have the required documentation explaining why they used audio only. The department would also like to take a moment here again to thank our aforementioned partners in this project, Vermont Care Partners, the Vermont Association of Hospitals and Health Systems, Bi-State Primary Care, and Vermont Health First, as well as the Vermont Medical Society, the Clinical Utilization Review Board, and the Medicaid Exchange Advisory Commission. We've heard some very supportive feedback from these partners, and we are glad to be engaging with the provider community on this. DVHA greatly appreciates this work stretching back to 2022 to review decisions, provide input, and collaborate on monitoring providers. Looking forward, we will continue to conduct our analysis. DVHA is monitoring, developing research. DVHA is monitoring, developing research through a clinical lens, considering utilization, and working with our partners to set policy on audio-only services. We appreciate hearing what VPQHC and DFR had to say in their testimony, and we will continue to look to them on this in the future. Go to the next slide, and thank you, Madam Chair and members of the committee. This brings me to the end of my prepared remarks, and I'm happy to answer any questions I'm able to at this time.
Great, thank you. So there's been no decision yet about 2025.
Correct.
When would that type of decision usually be made?
I will have to get back to you with that.
Okay, that'd be helpful.
Yeah.
Leslie?
I know this question isn't for Alice, but I just want to get it out there, if I may. Because here I'm speaking as a clinician. So let's say I get a call from someone who is complaining of a urinary tract infection, and it's pretty clear that's what they have, and you know what they need because you talk to the patient, and you end up doing an audio-only visit, and you are treating that patient's standard of care. I just want a conversation somewhere about that, of what a clinician should be reimbursed for providing care by telephone that's standard.
So we're going to hear from Sarah Teachout next from Blue Cross Blue Shield, and she's listening. So she could probably respond from an insurer's standpoint. Not right now, Sarah, but we'll come back to you. And we're also going to hear from Vermont Medical Society from a clinician standpoint. And then at the end of the day, that's the question on the table.
Thank you. So going off of DVHA's concerns that you've noted in there and what Leslie is saying. So previously, prior to the pandemic, you did not pay for audio only. You didn't pay for the telephone codes. So the telephone codes, the requirement is that you cannot bill for one if you've seen the person within 7 days prior. And you cannot bill for one if it then leads to an in-person for at least 24 hours. So, I mean, the case that Leslie noted used to happen all the time, still does happen all the time. You just didn't pay for it. So DVHA's concern is now, though, that providers are going to actually bill for the care they were providing all along. Is that the concern? I mean, because there's very regulation around those codes and when you can bill them.
Yeah, I think that the concern is cost drivers. We want to make sure that we're not creating a situation where we're paying over what we should be for members' services. I would need to get more information for you on a more specific answer to that question. But I think that the concern from our end is that we're balancing patient care and patient outcomes with cost to the state. And so we want to ensure that we are doing our due diligence wherever possible to bring those cost drivers down. And we see this as a potential area where that could be the case. We don't have any plans specific to change this at the moment. This is what the situation is right now. And at the moment, we are paying at parity for these services, and we don't have plans currently in place to change that.
Art?
Just a quick clarification here. Is text considered audio?
I would need to check that, but I wouldn't think so. No, I think that would be more falling under the what DFR outlined earlier with the yeah.
Storing forward.
Yeah, the store and forward
envelope icon.
Email thing. Yeah, all right, thank you.
I do want to comment on one thing, and this isn't for an answer for now, or a question that you have to answer now, but in looking at the table 1 on the VPQHC report, and this is going to be a question pretty much for everyone, except for maybe Cigna. Let me repeat. But the Medicaid, so if you look at 2018, 19, 20, 21, and 22, and you look at the, okay, forget it. Actually, I'm not looking at this right, so I answered my own question. I'm good. Thank you.
No,
Go ahead. You can ask. I was gonna
I'm gonna
ask.
ask, well, I think, I just want to be clear. So we're looking at that chart. So it has 3,636,000 professional services in 2018 for Medicaid.
What slide are we? Sorry.
It's slide, I don't.
It's actually in the report.
It's in Sebastian's slide.
Sebastian's slide. Okay, I was looking at.
And then in 2020, under Medicaid, there were only a total of 2,899,000. So that's a difference of like 800,000 services, professional services. And we just learned clearly there are lines on a claim. So I'm kind of astounded by this because our roles have been expanded so dramatically without redeterminations. And yet we're 800,000 services less in 2022 with our massive roles on Medicaid as compared to 2018 when we didn't have that many people. Isn't that utilization has gone way down despite the fact that we have so many more people on Medicaid, or we did in 2022?
So I guess I'm a little confused as to which numbers you're looking at here. Is this in table 1 of the report?
Yes, it's in table 1 of the report.
Payer service counts.
And so what we're seeing is a decline from 2018 to 2022 in what we're calling here lines on a claim.
In the in-person.
Well,
Combined, just combined all.
right. So if you look at the total, so 18 and 19 aren't totaled on the chart, but if you totaled them, it's still a decline. So it looks like, it's 3,640,000 in 18, 3,240,000 in 19, it's 2.6 million in 2020. It does go up in 21 up to 3 million, and then it goes back down to 2.9. So you can come back to us, but that's interesting, and maybe it's connecting with Steve.
The question is, why is there a decrease in
Decreasing,
claims
yeah.
when members have increased
Yes.
in that time? Okay.
And I believe, and I'm not going back to the budget, but I believe the budget has shown that utilization is increasing. So we're just trying to get it, and it might be something you need to talk with Steve Capel about and how these numbers were gathered.
To clarify, Madam Chair, overall utilization is currently decreasing.
It is currently
Now.
decreasing.
It was increasing for a while, and
Okay.
we are coming down from the height of the utilization from the public health emergency through the redetermination process.
Right, but this is saying it's come down from 2018.
And I will double check on that.
Okay.
I'm curious about that myself.
Okay, that'd be great.
Yeah.
Thank you. Any other questions on this? Great. Thank you, Alex.
Thank you so much.
Hi, Sarah.
Good afternoon. Thank you. Sarah Teach Out with Blue Cross and Blue Shield of Vermont. And I started not feeling well, so I thought I would spare you all and zoom in.
Thank you. We appreciate that. Hope you're feeling better.
So I will just talk high level a little bit about what Blue Cross and Blue Shield of Vermont did, and you've heard most of it. And then I provided some additional information that's specific to us that I think hopefully will augment your understanding. It's certainly not meant to replace the other broader reports that you already have.
Okay.
So, and before I ask Claire to put that up, I'll just speak quickly that Blue Cross and Blue Shield of Vermont recognized the necessity during the height of the pandemic for audio-only care and access to providers for our members and all Vermonters. In the longer term, though, our clinicians had concerns about promoting audio-only care as a substitute for audio-visual or in-person care. And we expressed those concerns at the work group that everyone has been discussing about. And there was a publication that we talked about, I think last time we were here, that was interesting. It was from RAND, and it was about rethinking the impact of audio-only visits on health equity. And so it was one of the things we were concerned with. I've looked to see if there are updates, and I'm glad that VPQHC provided you with some of the more recent studies, because there have been some interesting, there's some interesting work in this area, but none of it's, of course, perfectly on the questions that you're asking today. But we were concerned about how the ongoing delivery of audio-only visits can reduce the quality of care among low-income populations and contribute to health disparities. We noticed, or not we noticed, but the study noticed that clinicians can miss visual cues and struggle sometimes with establishing a rapport with patients, and the visits are generally shorter. And then patients report lower satisfaction and comprehension rates with an audio-only visit. And then the other thing that the study pointed out was that telehealth experts were worried that allowing audio-only visits at parity with in-person and audio-visual risked escalating costs, which you've heard already as a concern, and creating a two-tiered system where affluent patients get video and in-person visits and low-income patients get telephone calls. So that was one of the concerns we had, and part of the reason we made the decisions we did about our policies about audio-only care. There has been one newer study that's come out since then that I noticed, but it was in JAMA, the Journal of the American Medical Association. It was August 22, and it was specific to FQHCs in California. So it was a much narrower look than I think what we're doing here. But it said that audio-only visits still accounted for 1 in 5 primary care visits and 2 in 5 behavioral health visits among people visiting FQHCs. But that was California. So I thought it would be helpful to show the data. Blue Cross and Blue Shield of Vermont had read studies indicating that for mental health and substance use disorder, especially if there was an established relationship between the patient and the provider, that audio only could be equivalent to an in-person or audio-visual visit. And that was the basis for our decision to allow 100% reimbursement for mental health and substance use disorder visits and 75% for all other. So I don't know if Claire, I cannot put up the visual from my iPad, but I can speak to it if you can all look at it.
Yep, we can look at it.
Okay, perfect.
Oh,
So
Claire put it up.
Thank you, Claire. I really appreciate it. So just to be very clear, this is just Blue Cross and Blue Shield of Vermont data. The top bar is data based on claims amounts, and then the 2 bottom circles are claims numbers of visits. So they're slightly different looks at the same thing. We have what we call period A and period B. They're the exact same number of months. And they're looking only at audio only, not all other telehealth. So it's a much, I think, narrower slice than what you were seeing from the other data. And I've named the codes, and I think we should all acknowledge that
Are you there, Sarah?
That's,
yeah, hey, Sarah,
sorry,
you went out on us. So can you start with, let's all acknowledge something about the codes?
Yes. So the codes that we're looking at in the first period are not complete. So we allow visits and billing as if it was an in-person visit or an audio-visual visit. And so this, I know, undercounts the number of audio only, but we certainly don't know the full amount. January 22 is when DFR established the modifiers V3 and V4 to identify audio only visits. And so we're confident in the data in period B. So I just, just to say that the top bars are non-hospital owned provider visits. The yellow is hospital owned, and other, the gray, is out of state or out of network providers. And you can see that even though the bars are small, that diminishes considerably as you go along. So so I think I said there was no, Blue Cross and Blue Shield of Vermont did not pay for telephone calls at all prior to March 2020. Between March 2020 and December 21, we covered those visits, but in our data, it's very hard to identify what is an audio only visit. So this is what we are able to identify, but we do believe it's an undercount. And then from January 22 to present, we have the new modifiers, and the payment was set up for 75% of an in-person or telehealth visit for anything that wasn't mental health and substance disorder. So then to go to the two circles at the bottom, we broke it out a different way. So now we're looking for those 2 period in times the number of claims. And we looked at specialist visits. So it's that's anyone that's not a primary care provider, but is billing on the professional fee schedule. Mental health and substance use facility, which are hospital-based, but we can't identify the type of provider. Primary care, and then other, which is what I said before, out of network or out of state care. So you can see that we saw a pretty big shift between mental health and substance use care through audio only and specialist care. The other ones didn't shift a whole lot in that time period. So then I'll go down to the next page, because I think some of what we want to know is difficult to answer, but we were trying to, if Claire, if you can go down to the next page, who is actually utilizing audio only of our membership. So we gave you the average age during the first period was people 65, and then the average age for the more recent period is 55. Both of those, just so you know, are older than our average membership age, which is in the 40s. I think it's 42 or 43. So predominantly slightly older Vermonters are using this. We have, like Diva, seen fewer visits and fewer members using audio only. So during the first period, there were 15,211 unique members using it. It's dropped to 10,310. But the average number of services each person is accessing is greater. So it was almost 2 before, and now it's over 2. And then I think the other question that we've asked is this being utilized by people in Vermont who don't have good, Wi-Fi or are in remote rural parts of the state. And it's a little bit hard to tell in the data. So I have the counties broken down for the first period, the second period, and then on the bottom right, I show the population distribution by county, so you can see, and it doesn't really appear that rural Vermonters use audio only any more than people living in, less rural parts of our state. For example, if you look, and I'm looking at period B, so the one on the right. And if you look at Chittenden, Grand Isle, and Franklin counties combined, and that's the MSA, they're using 29.9% of the audio only services, but they account for 35% of the population. But for all the other ones, the population is smaller, with the exception of Lamoille and Washington, than their actual population in their county. So back to the top, Windsor and Orange account for 14% of the population, but only 10.8% of the audio only visits. So it seems to suggest that this isn't necessarily being used by people in rural parts of the state. I did talk to our data analyst, and she said, hey, you could be having a visit with your provider who's down the street. We wouldn't know that. So, it's not perfect data. And then just a little bit of summary information. Audio only claims are only 3.9% of all our telehealth claims. So just like what you saw from VPQHC, they're a very small portion. We're counting total claims, not lines, but the outcome is similar. This was one thing that we found interesting. 33% of the instances of an audio only claim were within 14 days after a member had an in-person claim from the same billing provider. So about a third of them are the person is being billed for a second visit with the same provider. And it looks like it's follow-up calls. Again, it's hard to tell exactly what's happening. And then the last thing I tried to provide you, and it's really tiny font, is the age of people using audio only. So you can see it's very low for 0 to 6. And then it actually appears that people over 65 are using the most audio only services, and that could just explain, difficulty with technology or not accessing it. So I think what we would say is that, and you can, I won't speak to that anymore, but if you have questions about the data, I can try and answer it. What we would like to do is continue with the current policy of paying for mental health and substance use disorder at 100%, leave all the other at 75. And it doesn't appear to be a huge part of what people are using for care, but we do not want to encourage audio only visits over other modalities. So that's it for my testimony, and I'm happy to try and answer questions.
Okay. So I just want to confirm for 2025, you're planning on still doing 100% for mental health and 75% for everything else.
Correct.
Right. Any questions for Sarah?
Well, I don't know if you can answer this, Sarah, but I'm just curious, given that we have a provider shortage and people have to wait really long times to get in, especially for acute problems, sinusitis, whatever, is there a value in paying clinicians for audio only to get people care they might need?
We do think that there is value, but we don't think it's equivalent value.
But you're not paying for it at all, other than what you said, which was substance abuse and other stuff. You're not paying for like acute problems or that kind of thing.
We're paying at 75% of the in-person or audiovisual rate.
Oh, okay. So maybe I misunderstood, because you're saying you'll pay for all of it. There are codes for all of it?
Like Vermont Medicaid, we have a broad set of we had a very broad set of codes before 2022. We narrowed some of the codes after the sort of height of the pandemic, but we still have a whole, and I could give you the list, a whole suite of codes that we pay for audio only for. And we same standard that it needs to be medically appropriate.
And when you set those codes, is that set once a year? Could it change throughout the year? How does that process work? And I should have asked you that, Alex, too. So, but good, Sarah.
Yeah, I think we try not to set it more than once a year, and it's been pretty consistent because DFR has done this sort of annual review in the summer where we all meet, talk about the codes, look at changes from Medicare, and then set our policy for the coming year. There haven't been significant changes in the last 2 years, but there have been some shifts in the codes.
Okay, thanks. Leslie?
So I'm just following up. I'm just looking at the Vermont Medicaid audio only codes that was in one of the slide decks. And I'm not seeing anything for acute. Now, maybe I'm not.
Well, that's Medicaid.
Yeah, no, DIVA, but I think that she referred to DIVA codes. I'm just trying to understand this sort of in a more global way, I guess.
Okay.
But, and I get, Sarah, that that's not you. These codes are not your codes. I understand that. But I'm just trying to understand, Alex, if I could get some help understanding these codes.
I'm happy to share our policy that has all the codes we pay for.
That'd be great.
Great, thank you, Sarah. We have Alyssa and then Topper.
Just to let you know, I don't think you're going to have an answer to this, but I think it would be interesting to analyze. So I'm actually really curious about the 33% of instances of an audio only claim were within 14 days after an in-person. It would be interesting if you would analyze pre-pandemic claims that came in within 14 days that were in person for a person who had an in-person visit, and then compare and contrast that now with possibly people who were in and within 14 days had either telehealth, audiovisual or audio only visit, to see if those are sort of equivalent numbers.
I can ask. I'm certainly happy to ask. The other thing I was just thinking maybe would answer the question is how many in-person visits were followed up with another in-person visit within 14 days? You know, you have to go twice. I don't know.
Yeah, but, and that's exactly what I was getting at, but to contrast that with 2018.
Okay. I can ask. I'm happy to ask. I asked her a ton of questions and I got a few answers, but
You could ask, that would be great, but I think that's a really interesting perspective. So are we reducing the in-person, which is allowing other people hopefully to be seen while the other people are doing audio only?
Yeah.
Topper?
Thanks. I think I know the answer to this, but can you just tell me the difference between medically appropriate and clinically appropriate?
medically and clinically?
Yeah.
Ooh, I mean, I think that, you know, what we're looking for with that is you can't do a blood draw or diagnose something that requires that you touch someone or take their temperature or do something like that. But I'm no expert, so I could get you what it actually means, but we're adopting American Medical Association standards, not our own specific standards.
Sarah, I'm not sure.
Maybe
Are you
I didn't
asking-
understand the question.
Yeah, are you asking if you have something that says medically appropriate or clinically appropriate? What's the difference between medically appropriate and clinically appropriate?
I
Is
have
there
no-
a difference?
Sorry.
Well,
Where are you
these
seeing that?
These terms are used interchangeably throughout all the presentations this afternoon. And if we're talking about audio only, I'm just trying to figure out how you can determine whether it's clinically appropriate if we're talking about audio only. I mean, how you make a decision? You don't do any of that, do you? If it's audio only?
So it's really, the decision is up to the provider?
Yeah, so let's ask Jessa that question. We'll ask, Vermont Medical Society is coming up next, Sarah, so we'll ask.
That sounds like an excellent way to go.
Any other questions for Sarah? Great, thank you, Sarah. I hope you feel better.
Thank
Yeah, thank you.
Jessa?
Afternoon.
And I do want to say, I asked Jessa to testify at like 11 o'clock, I think.
Yes,
So-
this one is not submitted or posted yet. I maybe will be able to clean this up in time. I will try my best. Yes, Jessica Barnard with the Vermont Medical Society, representing physicians and PAs, so clinicians on the ground doing this work. And I will just be right up front and say that our members support pay parity for audio only services. Reminding the committee that the legislature already requires parity for audio-visual services. So if you have broadband and you're in front of your computer and can turn on the screen, then your provider gets paid at 100% of if you came into the office. But if you don't have broadband and request and consent to doing this over the phone, your provider may or may not be paid for those services.
Wait, I'm sorry, can you stop right there?
Yeah.
So where do we require that providers are paid at 100%? Is that in statute?
That is in statute. That happened when I believe a year or two before. Oh, can I phone a friend?
I didn't know it was in statute permanently. I thought that was what was, and something's
Yes.
happening in 26.
So, in 8 BSA 4100K,
You're so good.
Sorry, it's Matt Wingo for the Department of Financial Regulation. We've had to reference this statute so many times. I feel like it will be seared forever into my memory.
Can you say it again for me?
Yes, 8 BSA section 4100K.
Thank you.
It's also included in appendix 5, we have.
Oh, okay, great.
Services,
Thank you.
including all of the payers, what they offer to reimburse that
Okay,
above and beyond what is required.
okay, great. Thank you. And that's not running out in 2026.
That's right.
Okay, great. Thank you.
Yes, thank you, Sebastian. Happy to phone, always Good to have a friend in the room. So, and a couple more notes on what the statute requires. So we're already statute has, well, first of all, as I said, requires patient consent. And the words you were just talking, the medically necessary and clinically appropriate services. So actually, this goes to your question, Representative McFawn, because it's sort of I think we're talking almost about two different determinations. So, and the statute, well, there are two entities making that decision in two different, potentially, hopefully the same way, but potentially different ways, which is that the statute allows the payers to come up with a list of services that they determine using whatever input processes they have internally to come up with a list of codes that they determine are clinically appropriate to deliver via audio-only services. So I encourage you to look at the policies by the payers. Some of them are actually fairly restrictive. So I don't have the latest in front of me. I was just trying to find it during this conversation. You know, Blue Cross is, and as they've mentioned, it's gotten smaller since the end of the public health emergency. You know, it's a list of, again, don't quote me on this, I don't know, maybe 20 to 30 services that they even will allow to be billed audio only at all. Then, of course, the provider needs to make a determination of whether they think under their clinical judgment, and the statute also holds providers to the same standard of care. So you can't say, you know, let me try this by phone and see if it works. You have to, you know, having realized why the patient is calling you, figure out if this would be clinically appropriate based on the patient or the nurse or whoever triaged the call, determining, you know, why they were calling you. So there's sort of two different entities making that determination of clinical appropriateness.
And also the Centers for Medicaid and Medicare.
And Medicare, if Medicare as a payer has their own list also, that has also gotten much smaller since the end of the public health emergency, but they are continuing to cover it at parity through the end of 2024. This year, there's been a lot of work in Congress trying to get them to extend it. Congress is, as you know, is complicated. But Congress actually is quite interested. So there's sort of a CMS process and a Congress process. There is a lot of interest in extending it. And I think, I don't want to speak for DVHA, but DVHA at Medicaid, they look to CMS to kind of say they think they have to give them the authority also through the Medicaid program to cover those same services. So Medicare does cover these services, some audio only services also at parity currently. And there's special interest, it's a little off topic, but a special interest around substance use disorder services. So there's been a lot of sort of federal level talk around allowing prescribing of buprenorphine via telehealth at large and also audio only. So the FDA is working on rules around extending that. It was allowed under the public health emergency, and sort of it's a little bit of a unanswered question about what exactly that will look like post public health or now when the current extension expires. Did that answer the question about clinical appropriateness? And I would say medical, I think that you said there was a medical and a clinical. I think those are just used I think people just kind of use the same.
Well, no.
Well, there's medically necessary and clinically appropriate.
Right.
So it has to be a necessary service. You can't just, which is kind of true for any service that you're billing for, but there's the medical necessity and then clinical appropriateness to deliver it via whichever modality you're picking. It's really the same for, audio visual as well. You may not be able to see something clearly enough even over the camera. You may need to do blood work. In that case, patient has to come in.
I think there's a lot of fingers in the pie.
It is, and that is actually a great point. And I think that is one, people haven't really talked about that. I think that is one of the reasons we're seeing the small portion of the pie that's audio visual and audio only. These rules have changed multiple, during the public health emergency, they were changing, it felt like weekly or monthly, of which payer was paying for which services, at what amount, what codes do you use, what modifiers do you use? I mean, practices were trying to, because it's certainly at the peak of the pandemic, the only way to get access to some services. But I will tell you, practices have given up. Kind of jumping to the end of what, at the 75% reimbursement rate for some of the services, that is also why especially smaller practices are just saying, forget it, I'm sorry. I mean, if you can't get on your computer, you have to come in. So I would argue that it's really a choice between coming in person and sometimes nothing. If a patient can't get there, they're just not coming in because the practice is saying, sorry, we cannot offer we can't talk to you on the phone anymore. We used to be able to. And then we won't even get into, there's the whole licensure piece, which has made some of it more complicated too. But it is very tricky for a practice to manage all of the administrative complexities of telehealth, offering telehealth. And I will say, you know, one of the big questions that we heard fairly from payers going into the public, well, in the height of the pandemic and when you expanded coverage was, are these going to be duplicative services? Is this sort of additive, or is this, you know, it's convenient, it's easy to do, let's just bill a lot of these services because it's easy and we want to talk, you know, and the patient calls, versus is it sort of substituting, instead of coming in, you are calling. And that we really appreciate VPQ's analysis. I mean, not any data is not perfect, but I think one of the big conclusions is we are not seeing an increase in these claims. In fact, we're seeing a decrease over time. So we really, from our perspective, are not seeing sort of an abuse of the system in any way. In fact, we think access is fairly limited to these services. Both for the commercial payers and DVHA. And we've really appreciated the collaborative work with DVHA. We've been meeting with Sandy Hoffman every few months to look at their data. And every time the conversation is, are you seeing, are there red flags? Are you seeing concerns? And it seems, really it seems like it's working pretty smoothly. They're not seeing sort of an explosion of claims or concerns about misuse. So we feel reassured by that. And that's under parity, they're already paying at parity and they're not seeing that. So an argument that, if we pay at parity, sort of we're going to see misuse of that. I don't think the data shows that.
Is there any data that shows the length of a audio only appointment?
So there are different sort of levels of audio only visits, and it is based on time. That's actually one of the big sort of changes after the public health emergency, how you bill for audio only, sort of what you would consider the equivalent of an office visit. So what we call those E&M visits, they're based on increments of how long you've spent on the phone with the provider. So I don't have that data at my fingertips. It might be something that could be, I'm sure we could look at, which are.
I pointed out, if I'm spending 20 minutes with a patient in person, but only 10 minutes on the phone, I can get more appointments in and make the money.
Right, so if you get paid less for those.
Right.
Under this system, you are paid based on that amount of time. So if it's a 10-minute phone visit, you would be paid less than a 20-minute in-person visit.
But if I get two of them in, okay.
I would have to look at the math.
I don't know if that's
point.
happening.
Yeah.
I have no idea, but I'm just, it seems to me that an office visit would take longer than a phone call. But I might be.
So I will get to that point. Yeah, I mean, one of the things we actually hear from our members who are trying to integrate these into their practice is they're actually really difficult to balance with an in-person practice.
Yeah.
Because these are typical, these have to be a fully billable service. So we've also heard the concern, this is just somebody calling up with your lab results and then they're just billing for it. Well, that does not meet, again, you've learned about the CPT this year. That is not a sufficient kind of appointment to be a billable, meet billable CPT requirements. So these are pre-scheduled, and you have to get patient consent. These are pre-scheduled visits, whether it's audio, visual, or phone. So, these will be in your appointment list like any other, but yet then say you have some lab work the patient does need to do or a referral. It's actually a lot harder to coordinate all of that when the patient's not in the building with your scheduler, with your nurse, with your receptionist. So to our members, these are actually more difficult. And that's probably another reason that there aren't as many. So some different offices have done it different ways. Sometimes they have a provider who's just doing telehealth that day. Sometimes you sort of do it at the beginning or the end of the day, but it's tricky to actually, unless, there are a few sort of fully remote or largely remote, say, mental health providers. But if you're thinking more like a primary care or specialty care practice, it can be hard to integrate them.
And then we're going to let Jessica finish her testimony.
Oh, yeah. Do you want to finish?
No, go ahead.
I'm just curious if your members ever talked about call and the time spent doing call and getting reimbursement for that.
On-call services, being on call.
Seeing patient after you're dealing with prescribe, providing service?
Yes, that's a great question. And actually, I've not asked that. I don't, if anybody out there is listening, or I can reach out to some of my colleagues to see, our practices billing for on-call services provided.
I don't know that they're codes.
Yeah, I was gonna say, if it meets a full visit requirement as opposed to more of a triage.
But not if you prescribe. It's not triage if you prescribe.
Right, exactly.
And a lot of that happens. I was just curious.
Right.
Yeah.
Right. I mean, I think you potentially could, if it was a full appointment, you've asked all the questions, you've sent in a prescription
Documented.
somewhere, documented it, you may be able to do that. And again, I know, especially early on in the pandemic, one of the concerns, and I saw it referenced in somebody's presentation, is unexpected out-of-pocket expenses for a patient. But again, there should be consent at this, now that we've sort of matured our telehealth infrastructure, this should not be a surprise to a patient. Oh, wait, this was an appointment that I have to pay for. It should be, do you want to do this appointment now over the phone, or do you want to come into the office? There will be a copay, if things are working the way they're supposed to and the way the statute sort of sets up the framework, that shouldn't be happening anymore. I know early on there were concerns about that. That's my comment. Sorry. So I did want to reference, so I had this is not totally up to date. This was from an older, a year or two ago when we were working with DIVA, actually on DIVA's reimbursement. We had some interesting data from some of our larger partners, so UVM Health Network and Dartmouth. So UVM, because that was more up to date. We didn't have the types of reports that VPQ is doing now, but they could look within their own systems of what they were billing. And so some of the most common reasons for audio-only visits were follow-up. So I don't actually necessarily disagree with Blue Cross about that, but that was actually something that providers really wanted to be able to do. Don't make a patient 2 weeks post-surgery have to figure out a way to get out of their house and come back into the office. This was actually really convenient. Chronic kidney disease, routine prenatal visits, nutrition counseling, anxiety, and pain. So again, yes, and some of the payers are paying at parity for how they define mental health and substance use services, but that's not always the only sort of chronic care type needs. And the visits were often from family medicine, orthopedics, surgery, cardiology. So there is a lot, we've heard that a lot from our members, like follow-up is actually this is a great tool for follow-up. We've just met, we've gone over this whole plan of care. Now I'm checking in to see how things are going, or medication management. We changed your meds 3 weeks ago. Let's have an appointment. Let's talk about it. How's it going? Can I see tell me your blood sugars, or email me your blood sugars, and then we can really talk about it and do this follow-up. Most patients, this is some data from Dartmouth about why audio only was being scheduled. And I heard that question earlier. Their data showed that 70% was for patient preference and 22% was for known technology issues. So lack of technology or broadband. And then there were some that were other reasons.
What percent was that, Jessica?
70% was patient preference or patient request. 22% was technology barrier. And they actually, interestingly, could track data. So this goes to a little bit to the rurality and access issues. They could track data based on failed video visits. That's another reason we hear. One of the main reasons audio only. We set this up as an appointment with audio visual, and then something happened. Your patient's Zoom wasn't working, their camera wasn't working, whatever it was. And that was one of the main technology issues. And the HSAs, the hospital service areas with the highest failure rates, were St. Johnsbury, Rutland, Bennington, Newport, Springfield, Windsor, and Randolph. And failed video visits were also highest in patients over the age of 65. So again, sort of different from what Blue Cross is seeing, older patients who couldn't make the technology work. So we are also concerned with the impact on access to care for older patients who lack resources and the transportation to get to the visits. So we would say this is actually an equity issue to continue to provide this service. And I mentioned some of the time issues, so I don't think I need to say that again, but again, just the scheduling, the coordination, the follow-up is actually more time intensive to do. That's true for audio only and audio visual. But again, there's the reimbursement differential. So thank you very much for having me in. I think I got through all the points I wanted to make, but we would encourage the committee to look at payment parity for all those medically necessary, clinically appropriate services for the commercial payers, but I will say also for DIVA. Again, DIVA has been a great partner. We really appreciate that they are continuing. But as you heard, it's sort of in their policy determination. It's up to them at this point. There is nothing in statute requiring that to continue. And in our view, some of DIVA's patients are the most vulnerable and challenged to get to appointments. And again, not always in a known way that could be accounted for. Like I was supposed to go to this appointment and my car just broke down. So it's either you don't come in today and we have to schedule you now, your appointment's 3 months from now, or we can switch to a phone visit if it's clinically appropriate and do that over the phone today. So that would be.
So I have a question and then I'll open it up. So from what I'm hearing from your testimony, correct me if I'm wrong, is you're kind of saying two things. One, you'd like to see parity for audio only, and you'd like to see the services that would be under that expanded.
That would be wonderful too. I think we are comfortable. I couldn't come to you today and say what, I have not done that sort of crosswalk of here's what each of the payers are currently paying. I will say the statute allowing the payers to come up with their definition of clinically appropriate has led to a restriction in the types of services that are reimbursed that way. That's sort of the reality of the current language. But I think, some of the main ones I will say, like DIVA, for example, is continuing to cover those audio only sort of office visit appointments. Those to us are some of the most important. And I would have to look again, like a payer by payer, are they all paying for those visits? Because to me, those are some of the ones our members use the most frequently for services.
If you could get back to us on that.
Sure, I'd be happy to look into that. And then yes, the pay parity piece, important.
Any other questions for?
I have one. Maybe this is for the payers. Can the payers be more restrictive than the Centers for Medicaid? They can be more restrictive.
Yes. And they could also be more expansive. I mean, except DIVA, I believe, but certainly the commercial payers could pay more broadly than Medicare. I mean, Medicare doesn't get everything right all the time either, but.
What's the sense of having the Centers for Medicare and Medicaid? What's the sense of having their list of what you can and can't do?
That's for them paying as a payer for Medicare. So that's what they make their own list for Medicare because they're the payer for Medicare.
Okay. So the other people aren't covered by that.
Correct. It just applies to their own people who have traditional Medicare. And I believe Medicare Advantage does not even have to follow Medicare. It's just fee for service. It's just they do their own thing also. It is just fee for service Medicare. They have this whole process that involves many categories of which services they pay for both audio visual and audio only. And it takes quite a long time to get them to change that, which is actually why Congress is thinking of kind of forcing them to say, yes, keep paying for audio only, because it actually might be easier for Congress to make that change than.
Aren't we trying to get everybody under one system?
Alignment is always nice.
Medicaid, whatever they're doing or whatever.
We're trying to do alignment where we can. We in this table are trying to do alignment.
Yeah, that's what I thought.
Yeah.
So I'm hearing a lot of discrepancy between everybody.
In this case, there definitely
Who
is.
suffers from this? Who gets hurt? Who gets impacted in the?
Well,
next negative?
Vermonters, because if it's too complicated for providers also, but ultimately, if providers say this is too complicated or I'm not getting reimbursed for these services, they just don't offer them. And then it's the Vermonter who can't, if they, an appointment that's not in person.
I get it.
Art and then Melissa.
Well, how many people are we talking here? When I think of audio only, I just think of a very small number of people. I don't know. I mean, I know we looked at the figures, it was that little teeny line.
Yeah, Blue Cross had 10,000, I think, on their,
10,000,
just on one insurer.
Yeah, but that's 10,000 hits.
Oh,
It's not-
yeah, it was 10,000 individual lives, they said.
When you look at the Blue
That
Cross.
are audio
Blue Shield
only?
data, yeah.
That are primarily audio only. Where's that? Where is that?
That's under Sarah Teach Out's data that she just sent. So it's on the committee page. Alyssa?
And I guess I think I was talking about what Topper said about alignment. I believe in that act, we made DIVA, so Vermont Medicaid, align with Medicare. But that's all we could possibly do. We couldn't make everybody else align. Like on what's covered and what's not.
I'm sorry, say that again.
No, I mean, because Jen went over that with, in that statute, we have where Medicaid has to follow Center for Medicare and Medicaid Services, because that was the only people we could say you have to follow. We couldn't do the commercial
Okay,
care.
then how could we, if that's the case, and I'm not gonna try to dispute it, when we did the contraceptive bill, we made everybody do it. So why can't we make everybody do this?
I was a freshman at the time.
Rita Sebastian answer that question.
So Representative Buckbaum, Sebastian Arduino again for the financial regulation. When the legislature enacted the contraceptive bill, what it was doing was taking that portion of the Affordable Care Act and enacting it as a matter of state law, because at the time, the concern was that Congress would either repeal the Affordable Care Act or that it would be struck down by the Supreme Court. With respect to the codes that different payers allow to be reimbursed by audio only, you're right that there's not alignment, and for example, the state could use the what's permissible under Medicaid's state plan as the minimum floor for what everyone has to cover.
So we could do something.
You could do something.
And I would just, if I could comment on that, I would agree with the suggestion to use that as a floor, because in this case, actually Medicare has been fairly conservative on what they cover. And I believe, and I don't want to, maybe Jen is the right one to clarify this, or Diva, that actually the statute, it's not that it necessarily required Diva to follow Medicare. It was just saying that Diva didn't have to deviate from what Medicare allowed. So I think there was a concern of whether they would be allowed to cover more than what CMS allows. So sort of Medicaid and Medicare are kind of pegged to these federal decisions. But there are instances, and I think there certainly are in Vermont currently, of the private payers covering more services than that. Again, it differs by payer, but you wouldn't necessarily want to require complete or only aligning with that, because that would actually limit audio only services.
Jen, did you want to say something?
Jennifer Carby, Legislative Counsel. Just wanted to clarify, I guess, that we often refer to what the federal government will allow for Medicaid because they do limit our flexibility, but the state has much broader flexibility to regulate commercial insurers. So if the legislature had wanted to align the coverage for audio only, to have the health insurers do something, whether it's the same as Medicaid or more than Medicaid, or set a floor, as Jessa was saying, I mean, you can do that through state law. You can't do it for the self-funded because we don't have authority over them.
Yeah.
But you can do it for commercial insurance.
Great, thank you, Jen. Thank you, Jessa. Do you want to testify?
No, I think Jessica covered it very nicely.
Okay, great. Okay, so any other questions? We're gonna come back to this. I think we have, I think the number one question we have as a committee is, and after this year, we don't do anything, insurers can do what they want. We have heard that Blue Cross Blue Shield intends to continue. Medicaid hasn't made any decisions for 2025. MVP couldn't be here today. So do we put something in statute around this? That is the question on the table that we will come back to. And also think about if there's others you need to hear from to help us make that decision and let me know. We don't have a bill for on the wall for this, but it is something that I think we have to resolve. Either by saying we're going to do something or by making the conscious decision saying we're not going to do something. So we will come back to it. Any questions or comments? Okay, so let's take a 10-minute